Hello, my name is Ibrahim Khalil, presenting our case report, Threading the Needle, Coumadin Ridge Papillary Fibroelastomas Complicating Left Atrial Appendage Occlusion. We have no relevant disclosures. Papillary fibroelastomas are uncommon primary cardiac tumors, usually presenting as left-sided valvular masses. Guidelines are not conclusive on the management of small asymptomatic fibroelastomas. We present two cases of incidentally found papillary fibroelastomas adherent to the Coumadin ridge during left atrial appendage occlusion device planning and placement. These cases highlight the increasing frequency of incidental masses with the expansion of percutaneous procedures, indicating the need for definitive management strategies. Our first case is of a 76-year-old female with paroxysmal atrial fibrillation and recurrent GI bleeding who presented for consideration of left atrial appendage occlusion. Pre-planning transesophageal echocardiography revealed a 0.6 by 0.1 centimeter mobile mass arising from the Coumadin ridge despite prior use of anticoagulation, concerning for a fibroelastoma. We see here on a mid-esophageal view on transesophageal echocardiography a thin finger-like projection arising from the Coumadin ridge. We see here the surrounding structures, the left upper pulmonary vein, the ridge itself, the left atrial appendage, and the left atrium. On video, we see that the mass is quite mobile. We use three-dimensional transesophageal echocardiography to better characterize this mass in relation to the surrounding intracardiac architecture. She ultimately underwent successful left atrial appendage occlusion device implantation using a cardioembolic protection device. She has since been de-escalated to single antiplatelet therapy with stable appearance of the fibroelastoma on subsequent monitoring. Our second case is of an 83-year-old male with permanent atrial fibrillation and recurrent epistaxis who was referred for and underwent uncomplicated left atrial appendage occlusion. Follow-up TE, however, noted a 0.3 by 0.1 centimeter linear mobile mass arising from the Coumadin ridge despite use of dual antiplatelet therapy, concerning for a fibroelastoma. We again have a mid-esophageal view on transesophageal echocardiography showing this thin finger-like projection arising from the Coumadin ridge and the surrounding structures labeled here. We see on video that it is quite mobile. Three-dimensional transesophageal echocardiography again characterizes this mass in relation to the surrounding structures. Given the patient's age and comorbidities, surgical resection was deferred for monitoring and extension of his dual antiplatelet therapy. Subsequent TEE has shown stable findings and he has suffered no complications after de-escalation to single antiplatelet therapy. As we discussed, papillary fibroelastomas usually present on the downstream aspect of left-sided valves. The Coumadin ridge is a particularly unusual location for PFEs. Practice guidelines are fairly clear on the resection of large left-sided fibroelastomas for appropriate candidates to reduce risk of stroke and embolism. However, they are less concrete for smaller masses and for patients who are unable to undergo resection due to surgical risk. The use of antiplatelet agents is a consideration, but it's fairly scarce supporting data. As left atrial appendage occlusion has rapidly been adopted for reducing risk of stroke and embolism with atrial fibrillation, peri-procedural planning has posed the clinical conundrum of increased discovery of these incidental intracardiac masses. This is particularly challenging in patients whose comorbidities preclude them from surgical treatment or therapeutic anticoagulation, and especially when these masses occur near the site of device implantation, as our cases highlight. In conclusion, we present two cases of unusually located papillary fibroelastomas during left atrial appendage occlusion device planning and placement. These cases highlight the increasing frequency of incidental intracardiac masses as percutaneous procedures rapidly expand and indicates the need for further data regarding optimal management of these masses in such scenarios. Thank you very much.